All right. We're going to go over the knee. Okay, so we already went over the hip. So you notice I did the foot, then I did the hip. Well, the middle joint's the knee. Okay? Basically, the knee, and this is taken again from the gift community, Gary, Dave Tiberio, is the knee, the acronym, not the acronym, the kind of catchphrase for the knee is caught in the middle with nowhere to go and no place to hide. So we would typically say that 99%, and I would almost go as far as to say 100% of knee symptoms have nothing to do with the knee. Okay? Because if you look at what makes up the knee joint, all right, you kind of have two joints of the knee. You have the tibial femoral joint. Okay? So the tibia on the femur, all right? So we have that. And we also have the patellofemoral joint. So the patella in the femoral groove or trough right here, okay? Now, some people would throw the fibula in there, but I'm not going to put that in there directly right now. We're going to kind of keep it simple. So tibiofemoral and patellofemoral. Well, basically, if you look at the tibia, movement of the tibia is affected a ton by the ankle joint, right? Because the tibia is the ankle joint, the talus and the tibia. Well, the subtalar joint is the talus and the calcaneus, okay? So if the calcaneus everts, the talus responds to that, which is going to bring the tibia and the fibula along. Well, that's going to definitely affect knee motion. So that's one end of the chain, how the foot is definitely going to have a direct relationship to the knee. And now the other bone is the femur, right? Well, the femur is the hip joint, right? So if the pelvis internally rotates too much and my femur begins to externally rotate, that's going to create a motion at the knee. It's pretty easy to see that. So if the hip and the foot are getting along, the knee's going to be fine. Okay? So if we describe motions of this knee, okay, we know we have knee flexion and extension, right? Knee flexion and extension in the sagittal plane. Well, in the frontal plane, we have abduction. So we describe motions in the extremities by what the distal segment's doing on the proximal segment. So this is a deduction, or we commonly call it valgus, right? And this is this abduction, valgus. A deduction would be varus. Okay, that's in the frontal plane. Well, in the transverse plane, we have internal rotation, which is tibia internally rotating on the femur, or the femur externally rotating on the tibia, okay? And then we also have external rotation, which is tibia externally rotating on the femur, or the femur internally rotating on the tibia, okay? They produce the same motions at the knee joint, okay? So, we have knee joint motions, all right? We got that covered, all right? So, let's remember that in the front leg and gait, when I land, okay, my tibia, my calcaneus everts, my talus falls down and in, my tibia internally rotates. My femur is also internally rotating, but the tibia is moving faster, so I get true internal rotation at the femur, right? You remember I hit on my heel and I actually go through dorsiflexion at the ankle. Well, if my dorsiflexion at the ankle is the tibia coming forward, well, if the tibia comes forward on the foot that's on the ground, that's going to produce knee flexion. So they're linked right together. What this is doing, this is doing, okay? Now, if that calcaneus everts, the talus falls down and in, and the tibia abducts, that's going to create a little bit of knee valgus, okay? Now, up above the chain, that internal rotation of the tibia and the femur internally rotating is going to internally rotate the hip joint. That's good, because remember, that's winding up the back butt. So that winding up of this back power butt, the hip source, the hip power, is going to decelerate the femur. It's going to thus decelerate the knee from internally rotating too much. So it's not that internal rotation at the knee is bad. It's the Goldilocks phenomenon, as Gary says. Too much motion is bad. Too little motion is bad. You want just the right amount, right? Goldilocks. Too hot, too cold, just the right amount, right? That's what function is. That's the magic of function. Just the right amount of motion in just the right plane at just the right time for just the right reason, okay? Now, let's say, remember I had in the sagittal plane, I had dorsiflexion at the ankle producing knee flexion. Well, knee flexion at the knee is hip flexion, because the femur is now flexing and the pelvis is anteriorly rotating. That's really good. Remember, the back butt's decelerating that. So the back butt can decelerate that knee flexion, thus indirectly decelerating dorsiflexion of the foot. Okay? Remember the knee valgus, right? So I get this motion, I get this knee valgus. Well, that is femur adduction. Adduction. Well, femur adduction with the pelvis going the opposite way is adduction of the hip. That's going to wind the hip musculature up. So we've loaded the back butt in all three planes of motion, which is great, which is really, really good. Okay? Because now that back butt, we've turned on the power source to decelerate the knee so we don't get too much motion. So all this thing we learned in traditional therapy, traditional training, we always learn, well, you want that knee to track right over the second toe. You don't want it to go in or out. Well, as I just described to you, you have no control over that. The knee doesn't have a brain, all right? The knee goes where the foot goes. The knee goes where the hip goes. So we have no control about that, all right? And I guarantee you, if you watch sport, if you watch anybody move, that knee is flying around in space all over the time. So if I just stand here, right? If I just stand here like this, and you look down at my right knee, and I look over my left shoulder, look where my right knee went. It's not over my second toe. My right knee just went through a ton of internal rotation. It went through a ton of valgusing, right? Did I tear my ACL? Hopefully not. It did that because it was driven. My cervical spine started rotating left. I ran out of motion in my cervical spine, so my trunk, my thoracic spine had to rotate left, which allowed my pelvis to rotate left, which drug my right femur along for the ride, which drug my knee along for the ride. So the knee is not like, it is not different than any other part of the body. It's going to go where it's driven, okay? If I step onto a curve on the side, or if I go to cut like this, my foot's going to be outside my knee. My knee is not going to be over my toe. That's not bad. That's not bad. That's not bad at all. So why in rehab are we constantly, I'm going to consciously train this knee to be right over that toe? Because we think that these motions of internal rotation and valgusing are going to put the ACL at a disadvantage. They're going to stretch the ACL. It's not that those motions stretch the ACL and that they're bad. It's that too much of that motion too quickly is bad. I still got to train it to go there because we know it's going to happen in function. Okay? So think about this. If I always train the knee in a controlled environment to stay right over the foot and never go through valgus or varus or any of that, what happens when I get out in life and all of a sudden I turn and I go there and the knee has to go there? It's driven to go there. Well, I've never allowed my body to do it. I've never trained the proprioceptors to learn how to go there, control it, and then come back home. Okay? If I've never done that, now I've actually detrained that knee. Now that knee is susceptible for an ACL. Okay? So it's not that the fact that the knee goes into those motions. It's if the knee can go into those motions and come back out, that's good. But if it goes into those motions and stays there, that's when we're going to have a problem, right? So you see kids all the time. Kids never tear their ACL, right? They go through all kinds of crazy motion. You think they're consciously saying, hey, knee, stay right over this second toe. Don't move because I don't want to tear my ACL. No. It's that they are understanding they have no restrictions. They have a nervous system that's highly trainable. It's highly reactive. And it can learn how to say, if I go there, I know how to decelerate it from the foot and from the hip. Because I have those two paths clear, which is going to allow the knee to control its motion and to create the stability. Because if you look at the knee, there's not a lot of muscle there. There's no muscle around the knee, not a lot of power source. Where's the power source? Boom, way up here. And you got the big calf and all the powerful muscles of the foot. So the power source is here. So the foot's job is to turn on the hip, the power source, via the knee to allow the knee to control. Okay? Thank you.